Okay, thank you. So my
Beautiful,
topic,
beautifully evolved. Yeah.
first of all, I want to thank that you have given some topic for icon 23. So the topic is dying rhythm. So let's start. So what are the rhythms which causes death? Sinus arrest without escape beat, complete heart block without ventricular escape, ventricular fibrillation or fast ventricular tachycardia with hemodynamic compromise, like this patient. This patient came with syncope and no ventricular beats, no atrial beats. He is having cardiac arrest. Cardiac massage was done, and immediately temporary pacemaker was put in and found to be having electrical standstill and assist. So here we put TPI, and with TPI he recover, and then we put permanent pacemaker, dual chamber permanent pacemaker, and he is alive. So ventricular asystole ECG review showed asystole can also be related to intrinsic conduction system disease. In this situation, the pause of electrical activity may be brief and result in syncope. However, spontaneous recovery of sinus rhythm may occur. Treatment for this form of asystole is permanent pacemaker implantation. But those patients who come with cardiac arrest like this, having chest pain, they may be having late presentation of VF with asystole. They need cardiac desynchronization immediately and followed by re-ECG and repeated desynchronization. DC cardioversion should be done to bring the patient into rhythm if they have a chest pain because of myocardial infarction, VF, and late presentation. They will have like this. Then patients having prolonged ventricular asystole because of paroxysmal complete AV block, where lot of one ventricular extra give rise to multiple P wave, which is non-conducting. This is called phase 4 heart block, where it requires, is a cause of sudden death, where requires permanent pacemaker. It's an absolute indication for permanent pacemaker. And patient may not have conduction system disease from beforehand. Only one ventricular ectopics lead to, or atrial ectopics lead to complete AV block, ventricular asystole, where PPP will be there without ventricular beat. And once one junctional beats will come, or atrial premature beat will come, the ventricle recover. So here there may not be intact Hesian conduction defect from beforehand. Suddenly it will appear, but most commonly if the patient is having intra-Hesian conduction defect or infra-Hesian conduction defect. So this is called paroxysmal AV block, which is different than that of the, like this patient having RBBV first degree heart block, left intrahemi block, and develop this type of block. Here, how will you distinguish from paroxysmal AV block due to AV node disease, AV conduction, that is vagal effect, where you will see PR prolongation from baseline, but on during PPPP, that is the arrest, where only PP will be there, the cycle length is shorter. Subsequent cycle length is relatively shorter as compared to baseline, because if there will be AV block, the cycle length will be prolonged, PP interval will be prolonged if it is because of the vasovagal reaction or vagal effect. So vagal AV block, that is called vagal AV block. Whereas in paroxysmal AV block, it's always cycle length will be shorter than the sinus cycle length. And this is the mechanism. This is called phase 4 conduction block in the Purkinje fiber. So this is same thing has been demonstrated. And this paroxysmal AV block, as I told you, require permanent pacemaker and is an absolute indication for permanent pacemaker. So same, this is one of the patient having atrial ectopic led to ventricular asystole, and one ventricular ectopic led to recovery of the patient. This is the same patient, similar patient. I can show many of them. Now I am going to show you another patient, short couple PVC induced torsade D points recurrent VF. So this 69-year-old female underwent SOL lesion surgery of brain 3 months back, presented with history of recurrent syncope. She underwent echo, which showed no regional wall motion abnormality, ejection fraction 60%, CAG showed normal coronaries, electrolytes were within normal range, 24-hour Holter showed short couple PVC induced TDP, that is torsade de points, polymorphic VT and VF, spontaneously recovering to normal sinus rhythm. Her baseline ECG is normal without QT prolongation. She was admitted in CCU where she is having recurrent cardiac arrest 9 times during the cardiac defibrillation, and monitored during cardiac arrest showed VF like this. This is in the Holter, so long VF and recurrence long VF recovering spontaneously to sinus rhythm. This is another VF recovering to sinus rhythm. This is another onset of short couple PVC induced VF recovering to sinus rhythm. This short couple PVCs in couplets. This short couple PVC in some of them are biseminy, some of them quadriseminy, and this is the short couple PVC induced torsade which spontaneously terminated into sinus rhythm. And this is the same patient in Holter showing multiple episodes of VF recovering spontaneously with the sinus rhythm. And this is in CCU having VF needed cardioversion, sometimes spontaneously shock. This is another VF, several VF, almost 50 times VF has occurred in the CCU where we have cardioverted, and then this is another VF. And then what I did is all the antiarrhythmic drugs have failed. So what I did is put on left stellate ganglion bupivacaine injection by ultrasound guided, and then put on high dose verapamil 80 milligram 6 hourly orally, and flecainide 150 milligram twice daily. And after that, she had no VF, no shock, no BPCs, and this is the ECG, which is absolutely normal looking ECG. After 2 days of suffering, she got. Actually, the patient was admitted to other cardiologists, and they gave it to me. You control it. I cannot handle this type of VF. And so, how to do the left stellate ganglion block? This is longus colli muscle and T1 and C7 vertebra. The stellate ganglion is there, stellate like. So here you do the ultrasound and find out the carotid artery, and here you punctured. I will show you the Doppler here. This is called Chassagne tubercle, and Chassagne tubercle is convex. This is the artery. This is the longus colli muscle. You have to inject like this, and here Chassagne is C6. You have to come to C7 where the chest is horizontal line. There will be the transverse process of the longus. Transverse process of the C7 vertebra is horizontal, and between the carotid artery and the thyroidal artery, you puncture the needle, go here, inject the bupivacaine 5 to 7 ml, and the VF or VT immediately terminates. And this is the injectable area, and you can get rid of this disease. So she received about 50 DC cardioversion in CCU in 2 days' time, failed with all the initial antiarrhythmic drugs such as amiodarone, beta blocker, maxilatin, lidocaine IV, and therefore did vascular ultrasound guided bupivacaine injection at the bedside. Left stellate ganglion, which led to stoppage of any VT-VF and even short couple PVC. Started high dose of verapamil 80 milligram 6 hourly daily, along with the 150 milligram of flecainide twice daily. Then I put her on 2 dual chamber ICD and discharged within 2 days. And short couple PVC induced TDP is relatively rare disease and may lead to sudden cardiac death. This patient responded well with ultrasound guided left stellate ganglion blockade by bupivacaine injection on verapamil 80 milligram 4 times daily, flecainide 150 milligram twice daily. She is free of any arrhythmia, and over 1 year of follow-up, she is coming to show me without any shock over this period, and she is doing fine with this medicine. And these are the studies which are published in the literature. Similar cases has been shown, short couple PVC induced torsade and VF spontaneously recovering, and several of these has been shown. And these patients, and this patient is another one, short couple, another VF, and all this required is either you do PVC ablation, because this PVC arises from the Purkinje fiber, or you do left stellate ganglion blockade, and we did left stellate ganglion blockade. I can show you several of such cases. This is another VF like this, and thank you for giving me the opportunity to talk something about the dying rhythm.
Thank you.